All right. Well, here we are back again with Chapter 14, Airway and Ventilation. And this chapter has probably 240 some slides. So I'm going to break it up into a couple lectures. Um, Probably 40 of those slides are objectives, but we do need to state the objectives prior to every lecture so that we make sure that we achieve those. Some of the learning objectives that we hope to get through in this particular chapter is to explain the primary objective of airway maintenance and why it's so vitally important to start with making sure that the airway is patent and maintainable. We're going to identify some commonly neglected pre-hospital skills related to airway management. We're going to identify the anatomy of the upper and lower airway, as well as describe functions of the upper and lower airway. We'll define what a gag reflex is, what atelectasis is. We'll explain the differences between adult and pediatric airway anatomy, as well as explain the relationship between pulmonary circulation and respiration. We'll list the concentration of gases that comprise atmospheric air. We'll describe the measurement of oxygen in the blood, as well as the measurement of carbon dioxide. We'll list factors that cause a decrease in oxygen concentrations in the blood. We'll list factors that increase or decrease carbon dioxide production in the body, and we'll describe peak expiratory flow as well as define FiO2. We'll describe the voluntary and involuntary regulation of respiration. We'll list factors that affect the respiratory rate and depth. We'll define and differentiate between hypoxia and hypoxemia, two words often used interchangeably, but they do mean different things. We'll define the normal respiratory rates, the normal tidal volumes of both adults, children, and infants. We'll describe the causes of respiratory distress and describe modified forms of respiration. We'll identify types of oxygen cylinders and pressure regulators that are used for oxygen therapy. We'll list the steps for delivering oxygen from a cylinder or a regulator. We'll explain the safety considerations of oxygen storage and delivery. We'll describe the indications, contraindications, advantages, disadvantages, complications, liter flow range, concentration of delivered oxygen for supplemental oxygen delivery devices like nasal cannulas, simple masks, non-rebreathers, partial rebreathers, and venturis. We'll describe the use of an oxygen humidifier. We'll define and explain the implications of partial airway obstruction with good and poor air exchange. We'll define complete airway obstruction and describe the causes of upper airway obstruction, as well as describe complete airway obstruction maneuvers. We'll describe the manual airway maneuvers, head tilt, chin lift, jaw thrust, those sort of things. We'll explain the purpose for suctioning the upper airway, as well as identifying types of suction equipment, and describe the indications for suctioning. We'll identify types of suction catheters, identify techniques of suctioning, as well as identify special considerations concerning the suctioning of the upper airway. We'll describe indications, contraindications, advantages and disadvantages, as well as complications, different types of equipment and techniques of tracheobronchial suctioning in an intubated patient, as well as identify special considerations of tracheobronchial suctioning in an intubation patient. We'll describe the use of oral and nasal pharyngeal airways. We'll describe the indications, contraindications, advantages and disadvantages, complications, techniques for inserting an oropharyngeal and nasopharyngeal airway. We'll define gastric distension. We'll describe the indications, contraindications, advantages and disadvantages, as well as complications and techniques for ventilating patients by the following resuscitation methods. We'll look at mouth-to-mouth, mouth-to-nose, mouth-to-mask. We'll talk about how inadequate one-person bag mask ventilation is. We'll look at two-person bag mask ventilation and three-person bag mask ventilation as well. We'll describe the indications, contraindications, advantages, and disadvantages, as well as the complications and techniques for ventilating patients using a flow-restricted oxygen-powered ventilation device, which is a demand valve. We'll compare ventilation technique used for adult with those used for pediatrics. We'll explain the advantage of two-person BVM. We'll describe the Sellick or cricoid pressure maneuver. We'll describe indications, contraindications, advantages, disadvantages complications, and techniques for ventilating patients with an automatic transport ventilator. We'll define and identify, describe a tracheostomy, a stoma, a tracheostomy tube. We'll define and identify and describe a laryngectomy, as well as how to ventilate a patient who has a stoma, including mouth to stoma and bag to stoma ventilation. We'll describe the indications, contraindications, advantages, and disadvantages, as well as complications, equipment, technique for inserting nasogastric tubes, orogastric tubes, and identify special considerations of gastric decompression. We'll describe the special considerations in airway management and ventilation for patients with facial injuries. We'll describe special considerations in airway management for ventilating pediatric patients. We'll differentiate endotracheal intubation from other methods of advanced airway management to include things like LMAs, combi tubes, and laryngeal tube airways. And that's what this next bullet point talks about, is the dual lumen airway, which is a combi tube. Then we'll also look at endotracheal intubation. We'll explain the risk of infection to EMS providers associated with ventilation. We'll describe a laryngoscopy for removal of foreign body airway obstruction, as well as describe the indications, contraindications, advantages, disadvantages, complications, and equipment, and the technique for direct laryngoscopy or endotracheal intubation. We'll describe the visual landmarks for endotracheal intubation. We'll describe the methods of assessment for confirming correct placement of an ET tube, and we'll describe methods for securing the ET tube. We'll describe methods of endotracheal intubation in a pediatric patient and how they differ from the adult. We'll also look at nasotracheal intubation, intubating a person through the nose. We'll describe the indications, contraindications, advantages, and disadvantages, as well as complications and equipment and techniques for digital endotracheal intubation, using your fingers to do the intubation rather than a laryngoscope and a blade. We'll describe indications, contraindications, advantages, and disadvantages, complications, equipment for rapid sequence intubation using a neuromuscular blockade, and that is essentially sedating and then paralyzing a person. So you could facilitate intubation in a conscious patient. We'll identify the neuromuscular blocking drugs and other agents used in RSI or rapid sequence intubation. We'll describe the indications, contraindications, advantages, disadvantages, complications, and equipment for sedation during intubation, and identify those sedative agents that we use during airway management. We'll describe the indications, contraindications, advantages, and disadvantages, as well as complications, equipment, and techniques for needle cricothyrotomy, and describe surgical cricothyrotomy as well. We'll describe the equipment technique for performing a surgical cricothyrotomy, which at this point in Iowa is not within the scope of practice of a paramedic, but it is within the scope of practice of a critical care paramedic. All right, so the primary objective of airway management is to ensure optimal ventilation. People don't die because we can't intubate them or we can't use some of the tools and toys that we have. People die because we don't ventilate them. And in order to ventilate them appropriately, they have to have an open airway. Oftentimes, because we are paramedics and we have all these tools at our disposal to manage a patient's airway, that we neglect the basics. We forget things like the importance of maintaining a good seal, the importance of properly positioning the head and the neck, the importance of reassessing the patient. Now let's look at the anatomy and physiology of the airway. And the airway is divided into an upper airway and a lower airway. The upper airway is from the vocal cords up, and it includes the pharynx, which houses the nasal cavity, the mouth and the teeth, the nasopharynx, the oropharynx, and the laryngopharynx. And pharynx just means throat. And then we have the larynx, which the structures of the larynx include the thyroid cartilage, which is the Adam's apple, the cricoid cartilage, which is just below that, the glottis, which is the leaf-shaped muscle that closes over the trachea when you swallow, and the cricothyroid membrane, which is an important landmark for doing a cricothyrotomy. And here's just a visual of, some of those particular landmarks. And what we need to consider or certainly appreciate about the upper airway is that when a person breathes in through their nose and the air rushes over those turbulates in the back of the nose, it is warmed, it is humidified, and it is filtered so that when it does go down into our lungs, it isn't cold. When we look at the oral cavity, certainly the first thing that comes to mind is the tongue. It's a very large muscle, and when a person is unconscious and lying flat on their back, it is a major concern for the potential for an airway obstruction. The uvula is a little flap that hangs down in the back of the throat, kind of wiggles when you sing. But the uvula, if a person develops uvulitis and the uvula becomes inflamed, people who snore really hard can wake up with a swollen uvula as well. And that can lead to a potential airway obstruction. Going further down, you can see the epiglottis there. It's a little leaf-shaped muscle that, by virtue of swallowing, it pulls that epiglottis down over the glottic opening so that liquids don't get into the trachea. Should they get by the epiglottis, we have an extremely effective, very aggressive cough reflex that causes us to almost cough uncontrollably until we get that liquid out of that area. The thyroid cartilage is behind that is located the vocal cords, and just below the thyroid cartilage is the cricoid cartilage. And between the thyroid and the cricoid is the cricothyroid membrane, which is where you would make a puncture with a needle to do a cricothyrotomy. It's important to note, too, that the trachea lies anterior to the esophagus. The esophagus is located then directly behind the trachea. And I bring this up because when a chest x-ray is done to confirm endotracheal tube placement, a chest x-ray, particularly if it's an anterior view of the chest, doesn't tell you proper tube placement. It just tells you tube depth. You need a lateral chest x-ray to know whether or not the endotracheal tube is in the trachea or the esophagus. When we look at the lower airway, that again starts from the from just below the vocal cords all the way down to the alveoli. So the lower airway includes the trachea, which as it comes down into the chest at the level of the carina, divides into the right and left main stem bronchi, and those bronchi divide into terminal bronchi, divide into bronchioles, and divide into terminal bronchioles, and then into alveoli, which makes up the vast majority of your lung tissue. You have over 700 million alveoli, and that's where gas exchange takes place. Unfortunately, not every one of those alveoli are open all the time. And when they are collapsed and closed, that's called atelectasis. And when atelectasis becomes severe enough or noticeable enough that it affects your gas exchange, your body will make you sigh. Some differences to keep in mind about the pediatric airway is that their airway flexes when they lie flat, and by flexing, the chin comes towards the chest when they lie flat, and this all has to do with the size of their head. The occiput is usually quite large in a smaller child, so when you lie them flat on their back, they have a tendency to hyperflex. The tongue is much more larger in their mouth in relationship to our mouths, particularly if they have something like Down syndrome. Their tongues are even larger than normal, and so there's just not a lot of room in the oral cavity, and if it's filled up with tongue, definitely if they're unresponsive and lying flat on their back, they can have a airway obstruction. The epiglottis is large and long and U-shaped, and it extends vertically beyond the opening of the cords. It lies quite anterior and can be, difficult to see because it's just right at the base of the tongue. Uh, the larynx in the adult is located at C4, between C4 and C7. But in a newborn, it is so anterior, it's so higher up that it's located at the area of C1 through C4. And the epiglottis in newborns can pass behind the soft palate and lock into the narrow pharynx so that they're unable to protect their airway when they swallow. At about 7 years, uh, uh, the larynx is located between C3 and C5. The trachea, a tracheal tube may move when the head position changes, especially if you hyperextend or hyperflex. When you hyperflex, chin to chest, when you bring your chin to your chest, that's enough movement, particularly if the endotracheal tube is placed properly, to displace that endotracheal tube into the hypopharynx. And the only way you're going to know that quickly is with end-tidal CO2 monitoring, and we'll talk in greater detail about that. Children have a tendency, their trachea, as it descends through the chest and gets to the area of the carina, where it divides into a left and right main stem bronchi, that area anatomically is more narrow. So it provides sort of like a physiologic cuff. So often in younger children, 3, 2.5, 2 size endotracheal tubes, we don't need cuffs on those because of that natural narrowing of the trachea. The diaphragm in children is flat, and the issue with that, one, the younger they are, they've not yet developed their intercostal muscles, so they rely primarily on their diaphragm to breathe. And when they get working hard to breathe, their diaphragm pulls their chest downward rather than expanding it outward, giving you a very noticeable seesaw type breathing. And when you see that overly exaggerated seesaw breathing, that's a good indication that respirations are inadequate because the chest is being pulled down rather than being allowed to expand out. Let's look a little bit at the physiology concerning respirations. Now, ventilation, the process of moving air in and out of the chest wall, occurs in 2 phases: inspiration. And what I want you to think about with inspiration is that that's an active process. It requires energy. Muscles have to contract and move. And what's important about that is, let's say you take that frail old COPD patient who may not have a lot of energy, and they get really short of breath and have to work really hard to breathe. That work of breathing can, literally expend all the energy they have, and to the point where they just can't breathe anymore because they have no energy to work those muscles. Now, our expiration is passive. It doesn't require energy. When the Herring-Brewer reflex is triggered, which prevents the chest from overinflating, when you reach a point where you've got a normal big breath, then ventilation stop, and the weight of your chest wall pushes the air out of your chest so that you can start with an inspiration all over again. The muscles of ventilation are listed there, and there certainly are quite a few. And again, the take-home message here is that inspiration is an active process requiring muscle movement, requiring lots of energy, and in situations where you don't have lots of energy, ventilation can be an issue. Respiration. You have both external and internal respiration. External respiration is gas exchange between the alveoli and the lungs. That's where red blood cells traveling through the capillaries in single cell fashion, one right after the other, as they flow by the capillaries, through a process of diffusion, they give off CO2 and they pick up oxygen. Internal respiration has to deal with, once the gases get to the tissue, how do they get out of the blood and into the tissue? And there's a variety of things that can affect that. Temperature, pH, those sort of things have a grave effect on the ability of oxygen to leave the red cell and go into the tissue where energy can be created. Now, hemoglobin, we can measure your hemoglobin, your oxyhemoglobin, and your oxyhemoglobin refers to the amount of hemoglobin that you have that is saturated with oxygen. Hemoglobin is an iron-containing molecule, and as such has a affinity to bond with oxygen, and we measure that in both arterial blood gas samples as well as pulse oximetries. Now, a PaO2, PA stands for arterial pressure of oxygen, is normally measured at 80 to 100 torr, which is the same thing as millimeters of mercury. So normal PaO2 is 80 to 100 millimeters of mercury, where normal PCO2 is 35 to 45 millimeters of mercury. And anything less than 35 can lead to respiratory alkalosis, and anything greater than 45 can lead to respiratory acidosis. When your body senses that your oxygen concentrations have dropped, certain compensatory mechanisms are enacted requiring you to take a deeper and faster breath in order to continue to maintain adequate oxygen saturations. Things that will cause a decrease in oxygen concentration in the blood include not having enough hemoglobin. You know, patients who are anemic can in fact have very good pulse oximetries, but if they've only got half the normal red cells they should have, they can still be grossly hypoxic. If you're dealing with lower oxygen partial pressure in the atmosphere, that can decrease the amount of oxygen in your blood. A pneumothorax or a hemothorax, anything that affects the normal mechanics of respiration, having to do with the muscles, having to do with the diaphragm, having to, that sort of stuff. Low inspired oxygen concentrations, areas where oxygen is, may not be in the right amounts. And then impaired diffusion across the pulmonary membrane. Anything that puts distance between the pulmonary alveoli and the capillary is going to make it more difficult for that oxygen molecule to diffuse into the bloodstream. And then impaired pulmonary blood flow. Obviously, if I have a pulmonary embolus and I'm not getting blood to the lungs I'm not getting blood to the lungs, I'm not going to be able to load oxygen onto the blood, and that's going to decrease my oxygen concentrations. Blood gas concentrations. Blood gases are something that as a paramedic you should really know how to interpret. As we become more involved in medicine, you're not going to do a blood gas in the field. You're probably not going to interpret a blood gas in the field, but certainly you'll pick up patients who may be acidic, may be alkalytic, and you need to know how to interpret those gases because that's going to drive your therapy and your treatment. Now, hypoxemia, by definition, is lack of oxygen in the blood. And treatment for hypoxemia includes ventilation and supplemental oxygen. Hypoxia is a decrease of oxygen in the tissue. So hypoxemia, lack of oxygen in the blood. Hypoxia, lack of oxygen in the actual tissue. Treatment for both is similar. You're going to make sure that you have adequate ventilation as well as adding supplemental oxygen. Now, hypoventilation is a term that refers to breathing too slow. And the issue with breathing too slow is that you don't blow off CO2 when you breathe slow. So CO2 builds up in your bloodstream because you're not blowing it off, and you get a CO2 excess, which is called hypercarbia. And hypercarbia is caused by not breathing deep and fast enough, or anything else that would decrease CO2 elimination, or anything that would increase CO2 production. Things like fevers will increase CO2 production. Things like strapping somebody flat on a board when they're having trouble breathing, and it decreases their vital capacity to where they can't get good breaths if they're strapped to a board lying flat. That's going to decrease CO2 elimination, causing the CO2 level to rise in their blood, causing hypercarbia. Now, hyperventilation, too much ventilation, just does the opposite. You end up with hypocarbia, not enough CO2 in the blood. And causes of hypocarbia include hyperventilation, increased CO2 elimination, or a decrease in cardiac output, perfusion or lung function interference, and decreases in CO2 production. When we look at terms associated with ventilation and respirations in the lungs, we look at terms like tidal volume. And tidal volume is the average breath that a person takes, the average amount of air that a person needs to move in order to have a normal breath. And that's usually around 500 milliliters of air. Now, dead air space is that space, that air that's in your oral pharynx, in your nasal pharynx, in your trachea, in your bronchi, that actually never gets to the alveoli. And if we look at the 500 milliliters of average tidal volume, about 150 of that is dead air space. And that's a constant. That doesn't change. Unless there's dysfunction to the lung, like a pulmonary embolus. Then you've got alveolar air. And alveolar air is the amount of air that actually reaches the alveoli for gas exchange. And that's usually, somewhere around that 21%. Now, minute volume is what's most important about ventilation, is minute volume. Tidal volume is the amount of air you move in one breath. But in order to stay alive, I have to move so much air a minute. If I'm moving adequate tidal volume, but I'm only breathing half as fast as I normally would, I'm going to end up moving less air in a minute and can get into some really big trouble. Functional reserve capacity and residual volumes, those are things that we would measure certainly to determine the effectiveness of our breathing treatments. Whether or not we're able to allow the lungs to take in more of a breath when breathing. So, total lung volume is the inspiratory reserve volume, amount of gas forcefully inspired, plus normal tidal volume. Expiratory reserve volume is the amount of gas forcefully expired at the end of a normal breath. Expiratory reserve volume is important because you don't ever really empty all the air out of your lungs when you exhale. If you did, all your alveoli would collapse. and then it would be difficult to get them all open enough again in order to change or help in gas exchange. Now, FiO2 is the percentage of oxygen in the air that you breathe, and FiO2 is measured in decimals, where an FiO2 of 1 actually equals 100%. So an FiO2 of 0.5 would be a 50%. An FiO2 of 2 would be a 20% oxygen concentration. Peak expiratory flow is the greatest rate of airflow achieved during a forceful expiration with the lungs. And we use peak flow meters to determine the effectiveness of a breathing treatment. You know, if you've got narrowed airways, you can only move a certain amount of air out with a forceful exhalation. If some of that's being trapped in there, you're not going to move as much out. So we can do a peak expiratory flow, give the breathing treatment, and then reevaluate the peak expiratory flow to see if there's actually an improvement. The control of respirations occurs in the medulla and the pons. You've got little chemoreceptors in the medulla and the aortic and the carotid bodies, and they're sensing for an increase in PCO2. They're sensing for a decrease in PCO2 and as well as a decrease in O2. If your body senses through the medulla an increase in CO2 production, it sends a message to your lungs and your diaphragm to breathe deeper and faster to blow some of that off. And the reverse is true. If there's a decrease in your CO2, that means you're breathing way too fast, and your brain would send a signal to tell your breathing to slow down. The respiratory center sends nervous impulses to the external intercostal muscles and the diaphragm via the intercostal nerves and the phrenic nerves to increase both the breathing rate and depth when necessary. And here's just a picture of the anatomy related to the parts in the parts in the brainstem where respirations are controlled, as well as the chemoreceptors and the stretch receptors in the carotid bodies and in the brainstem itself that constantly measure the CO2, the O2, those sort of things, and then send messages to the brain, which are interpreted, and then other messages are sent back to increase rate and depth of breathing in order to maintain adequate minute volume. Now, the normal respiratory rate in children is much faster than in adults. You can see that an adult's normal respiratory rate is 12 to 20, effortlessly, without pain, without noise. I always add that effortlessly, without pain, without noise, because it shouldn't be hard to breathe. If you're working at it, that's not a good thing. It shouldn't be noisy. Noisy breathing is obstructed breathing until proven otherwise, and it shouldn't hurt. There should be no pain associated with your breathing as well. So adults are 12 to 20, adolescents are 12 to 16, school-age children are 18 to 30, preschool children a little faster than that, toddlers and infants, they can really get going on the respiratory rate, and that could be considered normal. Now, semi-Fowler's is a position that typically we place people who are having trouble breathing. People who are having trouble breathing really don't like to lie flat. So putting them in a semi-Fowler's position, which is on their back at about a 45-degree angle, that does help them breathe easier. Now, respiratory distress certainly can occur as a result of either upper or lower airway obstruction. And one thing that you might hear in your assessment to determine whether or not this person had intended to, just a second, I lost my thought there. Anyway, upper and lower airway obstruction. When a person has upper airway obstruction, when a person has upper airway obstruction, we're going to hear a sound called stridor, and it's an inspiratory sound. It's an inspiratory sound that occurs when the upper airways are narrowed. When the lower airways are narrowed, when the bronchioles are constricted, we're going to hear wheezing. But wheezing is primarily an expiratory sound. Respiratory distress occurs as a result of, let me close this here, inadequate ventilation as well. When you have inadequate ventilation, of course, your oxygen levels are going to drop. Your CO2 levels may be affected. Those signals are going to be sent to your brain. You're going to increase or decrease your ventilatory rates. If you've got anything that impairs the normal mechanics of breathing, that can lead to respiratory distress as well. Any sort of muscle impairment, any sort of muscle injury, a hole in your chest, diaphragm injured, not working properly, any of those sort of things will lead to respiratory distress. And then a nervous system impairment, because certainly breathing requires signals to be sent from the sensory motor nerves. Closed head injuries can lead to respiratory distress as well. Now, dyspnea, by definition, the dys means difficult and pnea means breath. So difficulty breathing is called dyspnea, and it can be caused, or certainly can be present, when you have upper and lower airway obstruction. A person can be dyspneic with upper or lower airway obstruction. And how you might know that they're dyspneic is if they're sitting in the tripod position. They're leaning forward, their head's tipped back, they maximize the opening of their airway to allow them to get air into their lungs. They may only speak in 2 or 3 word sentences. You know, typically we should be able to string together 1 or 2 sentences without having to take a breath. But if they're just speaking in 1 or 2 or 3 word sentences, that tells you that their dyspnea is severe. And then orthopnea is the inability to lie flat. By lying flat, it becomes far more difficult for them to breathe, and that's called orthopnea. We already looked at this slide, I believe, once. No, we looked at the muscles, and these certainly are just landmarks of the chest. And things like the suprasternal notch, we need to know when doing a fast IO. Clavicle, you know, we'll use that as a reference point for finding the mid-clavicular line. The intercostal spaces between the ribs allow us to help count the individual ribs. The first rib is tucked right up under the clavicle, so typically the first rib you're going to palpate is actually the second rib. The sternum, that's where we place our hands for CPR, and then the xiphoid process located at the tip of the sternum. We can't have our hands clear down at the tip on that xiphoid process because we could snap that off when doing CPR. Now, certainly some physical findings that you might see that would indicate this person has a respiratory problem or an airway problem would include things like a big barrel chest. We typically see that in patients with chronic obstructive pulmonary disease. People with chronic obstructive pulmonary disease, they don't have trouble getting air out. They don't have trouble getting air in. They just can't get it all out. So they retain air. They become barrel-chested as a result of retention of that air. You may see paradoxical motion, particularly in things like a flail segment. If somebody has 2 or more ribs broken in 2 or more places, you're going to see paradoxical movement of the chest, where one side comes up and the other side goes down. Accessory muscle use, certainly the sternocleidomastoid muscles in the neck and the across the clavicle. If those are working hard, that's just a really good indicator of how severe the shortness of breath is. Pursed lip breathing, Pursed lip breathing is something that a person does to help provide just a slight increase in physiologic PEEP, positive end expiratory pressure. So a person who's using their lips in order to increase the pressure inside their chest to help them exchange gas better, that's called pursed lip breathing. Subcutaneous emphysema, that's kind of crunchy, crackly sound that we can feel or palpate under the skin of a patient. And that's what that means is when you feel it, you know that there's air in there between the, between the skin and the tissue. Crepitation is something that you hear when bone ends rub together. They kind of grate together, and you can feel it as well as you can even hear it. And then the 1 and 2 word dyspnea certainly is an indication of respiratory distress. And again, landmarks of the chest, mid-axillary, mid-clavicular, these are lines that we use when placing electrodes and listening and those sort of things, as well as the lines across the back. Now, auscultation or listening can be done audibly without a stethoscope, or you may need a stethoscope in some people, especially if they have what we call quiet dyspnea. Their rate is increased. They're working hard to breathe, but when you listen to their lungs, they're clear. They got 100% sats, and so you got to wonder why their breathing is increased a little. Is it something metabolic? Does it have to do with a hole in a bucket where the like a pneumothorax? Some of the noises that we're going to hear when we auscultate listening to the chest include snoring, gurgling. Stridor is that high pitch-like inspiratory noise that you hear with croup. Wheezing is a whistling that you hear in the lower airways. Crackles is just that. It's kind of like the sound Rice Krispies make when you put milk on them. And then rattles or ronchi, those are typically coarser sound, louder sounds that would indicate a lot of fluid in the alveoli. Some common abnormal patterns that you'll see with respiratory problems include bradypnea, which is slow breathing, tachypnea, which is fast breathing, hyperpnea, which is deep breathing, and then air trapping, which you'll see in patients who have asthma and who go into a condition that we call auto-PEEP. They get breathing so fast because they're short of breath, but because of their obstructive pulmonary disease, they don't let all the air out. And so air ends up being trapped inside the chest with each breath that you take, and it can create a mechanism very similar to a tension pneumothorax and drop your blood pressure. There are some recognizable breathing patterns as well that you can see. Cheyne-Stokes is something that you see with head injuries. It's shallow breathing, deep breathing, shallow breathing with a period of apnea, and then shallow breathing and real deep breathing, and then shallow breathing with a period of apnea. Kussmaul's respirations is what we see in diabetic ketoacidosis. With Kussmaul's respirations, that's very deep and very rapid. Not necessarily rapid, but very deep. Biot's respirations is something that we see in a terminally ill patient where they may have long periods of apnea and then really deep breaths. Central neurogenic hyperventilation is just that. It's caused from brain injury, and the patient just breathes really deep and really rapid. Agonal respirations, that typically is something that in an unresponsive patient is a sign of cardiac arrest. So why I would make my patient with respiratory distress a high priority patient, to me, is a no-brainer. If you're having trouble breathing, you're a high priority patient until we can prove otherwise. But things like severe shortness of breath, makes a person a high priority patient. If they've got any altered mental status or cyanosis around their, particularly around their central core, if they don't have breath sounds, or you hear stridor, or if they can only speak in 1- and 2-word sentences, or they're really working hard using their accessory muscles. These would all be good reasons to make this patient a high priority. Now, as far as supplemental oxygen goes, you know that we've got, D, E, M cylinders. D are the small cylinders, E a little larger than that, and then the M or the L is typically what's in the back of the ambulance as piped O2. Some of the delivery devices in spontaneously breathing patients that we can give to administer oxygen include nasal cannulas. Now, the advantages of a nasal cannula: it's comfortable, it doesn't interfere with patient assessment, it allows them to talk or eat, and they don't rebreathe the air that they exhale. But some of the disadvantages is you're not going to get really high concentrations with that, maybe 20 to 30% oxygen concentrations, and the patient has to be spontaneously breathing. And then we have the simple face mask, and it's defined here. The advantage of the simple face mask is that you're going to get a little higher percentage of oxygen when compared to a cannula. It does require a little higher flow rate, usually a little higher than 6, oftentimes 10 to 12 liters a minute. The disadvantage is the patient has to be breathing to use this. It's not tolerated in people who are really short of breath. If they're really short of breath, putting a mask over their face, they often feel like they're suffocating. And then it's uncomfortable, and you can't hear the patient when they talk. The partial rebreather is a simple mask with a reservoir bag on the bottom. But what makes it a partial rebreather is that one of the exhalation ports on the side of the mask is actually sealed with a little rubber disc that when you exhale, it allows air out, but when you tug hard and inhale, it slams shut so that all you get is the gas that you're delivering as well as the gas in the mask. The non-rebreather, of course, the advantages of a non-rebreather are that that's the highest percent of concentration that you're going to get in a oxygen delivery device for spontaneously breathing patients, because if fitted properly, the person only gets the air that's being delivered. If it's fitted properly, because of those flaps over the exhalation ports, when you start to inhale, you're going to take in the flow rate that you've set at 15 liters, but once you exceed 15 liters a minute in your inspiration, it's going to try to pull in room air, but it can't because of those flaps, so it has to pull in the air that's in the reservoir. And that gives you 100% oxygen. The disadvantages, of course, are the same as with any mask. Venturi devices are kind of making a comeback, and that's because of the need to not hyperoxygenate patients. Venturi masks, of course, the advantages are that depending on the flow rate that you set, you can twist the housing of the Venturi mask so that depending on the flow rate, you can deliver 24, 28, 35, or 40% oxygen. It is recommended for patients who rely on hypoxic respiratory drive, like severely ill COPD patients. Belief is, of course, that if we give them too much oxygen when they rely on that to take their breath, if they've got too much oxygen, then they may not want to take a breath at all, which could build up the CO2, which could lead to problems. The disadvantages with a Venturi mask are just like those with any mask. Okay, and of course, the whole purpose of giving supplemental oxygen is to prevent hypoxemia, but we don't want to give them so much that we make them hyperoxic as well. And the current guidelines state that anything pulse oximetry is less than 94% with a person who is short of breath, working hard to breathe, that sort of stuff. Excuse me, in respiratory distress, then we should give them as much oxygen as we need in order to keep that SATs above 94%, between 94 and 99. If they've got a pulse oximetry of 100%, one, that's physiologically impossible because 3% of your oxygen is dissolved in plasma, and you wouldn't detect that in a pulse oximetry. So if you're getting 100% pulse ox, that's way, way too much oxygen, and you need to back your flow rate down. Some delivery devices to administer oxygen also include small volume nebulizers and humidifiers. Small volume nebulizers is what you would use to deliver a breathing treatment in a patient who is having trouble breathing, as opposed to a little meter dose inhaler. Oxygen humidifiers is something that you should consider certainly on long transport times with patients who are on oxygen, because the oxygen may dry out their mucosa, and keeping it moist would make it more comfortable for them. As far as airway obstruction goes, the most common cause of airway obstruction still is the tongue. In order to relieve that, it's a simple head tilt chin lift. But also remember that foreign body airway obstruction also is a common cause of airway obstruction. Things like food, dentures, broken teeth, toys certainly can get into those airways and cause obstruction, particularly in children, because their airways are so much smaller and there's just not a lot of room back there. And of course, we've been taught that should a person have a airway obstruction, that we do the abdominal thrust or the Heimlich maneuver, and that certainly with infants we don't do that. We do chest thrust and back blows. And we don't blind finger sweep anybody anymore. We look. If we can see it, we dig it out. If we can't see it, we just leave it in there. Treatment for foreign body airway obstruction is to remove it with direct laryngoscopy, which is something that you can do as a paramedic by taking your endotracheal blade and handle and tube and attempting to intubate this patient. Laryngeal spasm or laryngeal edema, anything that swells those airways, are going to lead to potential airway obstruction. And again, we had mentioned upper airway obstruction, you're going to know it's present because of stridor, and lower airway obstruction, you're going to know it's present because of wheezing. Treatment for that includes things like, or reasons for laryngeal obstruction include things like epiglottitis, anaphylaxis, burns, toxic inhalation, or trauma, which, of course, that's the main things that we deal with. Okay? Aspiration. When somebody aspirates something down into their lungs, we have an extremely forceful cough mechanism to help get that out of there. Because if we aren't able to get that out of there, something as small as a tablespoon of aspirate into the lungs could cause a pneumonitis or a aspirate pneumonia that could kill them in a short period of time. Opening the airway requires us to do a head tilt chin lift. That's the most common way to open somebody's airway. One thing that we often don't include when we do this is positioning, and I think it's really important that we get into that. That if lying flat, if we notice that their chin is close to their chest or hyperflexed, then putting something under their shoulders will drop their head back so that you can open it easier. Contraindications to the head tilt chin lift include an awake patient or a patient with a possible C-spine injury. The advantages is it's very simple to perform. You don't need any equipment, and it's not invasive. Of course, the big disadvantage is it doesn't protect your lower airway from aspiration, and it may cause spinal movement. The jaw thrust without head tilt. This is in an unresponsive trauma patient, and this really is difficult to do. We'll practice this in the labs, but this is not something that's easy to do at all, because it takes pretty much all of your hand strength, and to jut that jaw up and hold that tongue up off the back of the throat. Very difficult to maintain a seal with a bag when you're doing that. Very difficult to do anything. Okay. Jaw thrust without head tilt, contraindications. If the patient's awake, they're probably not going to let you do that. The big, again, disadvantage is it's very difficult to maintain, requires a second rescuer. It doesn't protect the lower airway, and it does lead to spinal movement. So if you're unable to ventilate with the head tilt chin lift, then you might go to jaw thrust. And if you're unable to ventilate with jaw thrust, then it's life over limb, and you may have to hyperextend that airway and open it up. Suctioning is to remove vomit, saliva, blood, and anything else that gets in the airway, and there's a variety of suction devices. You're familiar with hand pumps and battery-operated and oxygen-powered suction units as well. Some could be mounted in and vacuum-powered in the back of the ambulance as a form of a fixed suction unit. Suction catheters can be soft or hard. And there's two different techniques for suctioning the upper airway and suctioning the lower airway. The hard suction catheters are great for upper airway obstruction, where the soft ones may be a little better for lower airway obstruction. To do upper airway suctioning, put on the appropriate PPE, assemble the necessary equipment, pre-oxygenate your patient before suctioning if at all possible. And then turn the suction unit power on, test for adequate circulation by sealing one side of the catheter with a finger, that should show a significant spike or increase in the pressure inside your portable suction unit. Determine the depth by measuring before inserting the catheter, so measure so that you don't insert it too deep. Begin suctioning, moving from side to side, holding the mouth open with one finger, and then draw the catheter out while suctioning, and then clean it up, and hopefully clean the suction catheter up by dipping it in water, and hopefully it doesn't get plugged up. When you're suctioning either the upper airway or lower airway, it doesn't matter upper or lower, you need to put on and assemble appropriate PPE. This can be messy, so including things like face shield or a surgical mask certainly would be appropriate. You want to pre-oxygenate them before you begin suctioning. Now, the whole purpose of pre-oxygenation is to flush the nitrogen out of their body. By giving them 6 really good breaths, you can flush the nitrogen out of their body, which allows you to take much longer for your airway procedures. Instead of having to be done by 90 minutes, you could actually take up to, 90 minutes. Instead of having 15 seconds, because we've all been taught not to suction more than 15 seconds. We could take up to 60 to 90 seconds as long as the patient's heart rate remained up and their saturations remained above 94%. So not hyperventilate them, but give them some good breaths. Turn the suction unit on, test it before sticking it in anybody's mouth. Determine the appropriate depth. Here they're doing lower airway obstruction through an endotracheal tube. So they've measured, they're inserting the smaller suction catheter into the tube after removing the bag valve mask or removing the ventilator, and then applying suction on the way out. And then hook the ventilator back up and ventilate the patient, but certainly reassess for lung sounds and reassess to make sure that if you had a lot of rhonchi or crackles in the bases, that should clear up. When opening the airway, I'm not sure how most of these complications would occur just by doing a head tilt chin lift or a jaw thrust, but certainly hypoxia from not being able to open the airway would be an issue. And dysrhythmias, pretty much If somebody is hypoxic or has hypoxemia, they're going to develop dysrhythmias as well. An increase in intracranial pressure, that occurs if you can't get the airway open and the CO2 levels build up. CO2 is a potent cerebral vasodilator, so as your CO2 levels go up, so does your intracranial pressure, which will decrease circulation to the brain. Local swelling of the airway from aggressive airway management techniques, shoving stuff in there when you're not sure where the tip is or where it needs to go, causing a lot of soft tissue damage and hemorrhage. That can be a complication of opening the airway as well. Ulcerating the trachea, infecting the trachea, causing bronchospasm, vagal stimulation, tachycardia, hypertension, and hypotension if it takes long enough. OPAs, oropharyngeal airways, they come in a variety of sizes, colors, that sort of stuff. They go from large to small. They're indicated to maintain an open airway for a patient who isn't intubated but has no gag reflex and is able to be easily ventilated with a PPV, positive pressure ventilation device. Contraindications include if the patient's awake and has a gag reflex, you're not likely going to put this into their mouth. It needs to be sized before putting it in. If it's too short, it can cause a complete airway obstruction as the tongue wads up in the back of the throat. If it's too long, it can push the epiglottis shut. It can also dilate the esophagus so that when you ventilate, the air goes into the esophagus. The advantages, it pushes the tongue forward, helps you hold the tongue up off the back of the throat. The disadvantage, it doesn't protect you from aspiration like an endotracheal tube. And, once you're assigned to do that particular role of opening the airway, if the person isn't able to manage it themselves, then that's going to be your job the whole time, keeping that airway open. Here they're showing you how to size for the OPA, and you'll do this in the lab as well, how to insert it upside down, turn it sideways, push it to the base of the tongue, that sort of thing, so that the flange rests on the lips, and then confirm by ventilating the patient. Another method is, and particularly is helpful in children, is to use a tongue depressor to hold the tongue out of the way, so you get a little better visualization of the glottic opening. NPAs or nasopharyngeal airways. Again, these come in a variety of sizes and colors and shapes as well. And the purpose of these airways are to put into the nose, and they too will help hold the tongue up off the back of the throat. Nasal airway adjuncts, why would I put a nasal airway in over an OPA if the patient has trismus or is biting the tube or clenching their jaws or chew their, grind their teeth at night or those sort of things? It could be a little hard on an OPA, and so using an MPA would work best for that. It's contraindicated for severe cranial trauma and if the patient cannot tolerate the procedure. Now, that whole thing with severe cranial trauma, you probably have been told that you don't stick anything up anybody's nose that has facial trauma because you might induce that into their brain cavity. Well, that occurred once in one person, and it's never occurred again. So, some would argue that you certainly should try to put an NPA in somebody with severe facial trauma, especially if they're unresponsive, and it more than likely is not going to end up inside the head. Advantages to nasopharyngeal airways: they provide an airway. They're tolerated by patients who are not deeply unconscious. Disadvantages: just like the OPA, they don't protect you from aspiration. They don't protect you from bleeding. It does make suction more difficult, and it may stimulate a gag reflex in somebody who isn't deeply unconscious. Caution must be used to maintain proper head position. Just because you put an OPA in or an NPA in doesn't mean that you can no longer maintain proper head position. Here they're showing you how to measure for an MPA. We pick the nair that looks the straightest and the largest. It's usually the nair on the same dominant side of their body. So if they're right-handed, it's usually the right nair. If they're left-handed, it's usually the left nair. You're going to lubricate the distal tip liberally with water-soluble jelly like KY jelly. You're going to warm it up a little bit, and then you're going to insert it through the nose, wiggling it back and forth as you slowly insert it, because you've got to get it up over those turbulence. You got to get it up over all that anatomy in the back of the nose. Once it goes up over that hump in the back of the nose, then you can easily push it down to where the flange of the nasopharyngeal airway rests on the nostril or the nasal opening. Some ventilation techniques are mouth-to-mouth ventilation, mouth-to-nose ventilation, and mouth-to-barrier device to ventilation. Now, mouth-to-mouth with a barrier device certainly might be all you have initially. If you're like me and most DMS providers, they'll carry a little barrier device on a keychain or something like that, so that if they needed it, they could provide mouth-to-mask ventilation until, or mouth-to-barrier ventilation until a mask arrived. Mouth-to-barrier device is no different than doing mouth-to-mouth like taught in basic life support. You just place the barrier device over the face and you seal it as best you can with your mouth on their mouth and ventilate into their one-way valve, and that should work. Mouth-to-mask ventilation is used to get a little higher oxygen concentration, and certainly that's one of the big advantages of mouth-to-mask ventilation is that it does give you a good sense of compliance with the lungs, because you're using your breath and your lungs to inflate their lungs. So if their lungs are stiff or hard or one's collapsed, it could be very difficult to get breaths in. You're looking right at the chest when you're doing this. You can see if you got good chest rise. You can use both hands to obtain a really good airtight seal. So there's a lot of advantages of using mouth-to-mask ventilation. You know, disadvantages, it certainly ties you up. You have to put on the proper personal protective equipment, put the one-way valve onto the mask, using either the C&E technique, which is demonstrated in the top picture, or the T&E technique, or the thenar technique, where the thenar muscles of the thumb rest on the cheek, and then you have 4 fingers instead of 3 to grab the angle of that jaw and pull it up off the back of the throat. Mouth-to-mask ventilation, you apply the apex of the mask over the bridge of the nose, or the pointed end of the mask goes over the bridge of the nose. You stabilize it, get a good seal, and then you lower the mask over the face and the mouth. You can use your index fingers to stabilize the base of the mask over the groove between the lower lip and the chin as well. Mouth to mask, you ventilate again through that one-way valve. You can see the chest rise. That's a good advantage of it. Now, bag mask ventilation. Instead of mouth to mask, using a bag to ventilate. Some of the advantages include an oxygen-rich mixture. You can get a much higher oxygen percentage than you can with a mouth to mask. You can feel the compliance of the patient's lungs. You can provide immediate ventilatory support. And you can use it in both spontaneously breathing and apneic patients as well. Big disadvantage, the number one big disadvantage, is that it's very difficult for one person to do. The American Heart Association no longer recommends one-person bag valve mask because it is so difficult to do. If you don't have a really good seal, you're not going to get adequate tidal volume. You're going to have the chest to rise a little bit, but we need the chest to rise fully every time that we give a breath. You can get tired trying to hold the mask and squeeze it yourself. You can get gastric distension if you squeeze the mask too fast. You can dilate the esophagus in whatever business you're in, and air will go down into the lungs. And causing gastric distension, which increases the risk of vomiting, as well as it makes your CPR ineffective. And it cannot be done by one person successfully. Here's an example of a bag valve mask. It's called that because there's a bag, there's a mask, and there's a one-way valve in between the bag and the mask. Without oxygen, you're going to deliver 21% oxygen. If you have a supplemental oxygen reservoir that hooks to the bag, you can get up to 40 to 60%. And at faster flow rates, you can get up to 90 to 100% oxygen concentrations with a reservoir. To do bag mask ventilation, you need to put your PP on, position yourself at the top of the spine at the patient's head, open their airway with one of the techniques that we had talked about, clear the airway of secretions or vomit, and then insert the nasopharyngeal airway and assist ventilations. Here they're applying the mask on the patient's face. You use the pointed side of the mask, goes to the top of the nose. The base of the mask goes over the groove between the lower lip and the chin. And if it's too large and hangs over, you're going to leak air out. If it's too short, what many people are doing, and it's certainly not correct, but if the mask is if the mask is too short or too small, it's going to be very difficult to get a good seal. If you're all by yourself, you can squeeze the mask with one hand, or you can squeeze the mask against your leg or chest. With two-person bag mask ventilation, this is what we should be shooting for. One person squeezes the bag, one person holds the mask onto the face using the Thenar technique like he's demonstrating here, or the C&E technique. Cricoid pressure is something that we're taught to do when inserting an advanced airway, and the purpose of cricoid pressure is to increase the view of the glottic opening by placing a thumb and a finger on either side of the thyroid cartilage or the Adam's apple. If you push straight back or straight down on that, that is supposed to, because of the cartilage bands of the trachea, that is supposed to collapse the esophagus and prevent aspiration. But typically it's not performed correctly, and as a result, intubations can be extremely difficult. If you're pushing down on the wrong thing and you're completely occluding the esophagus, or pushing so hard that the trachea itself becomes narrowed, it makes it difficult to pass an endotracheal tube. So cricoid pressure, the Selleck maneuver, although you'll see people use it, it is no longer recommended. Some things to troubleshoot when you're doing artificial ventilation is avoid overinflation. There's about 1,200 milliliters of air in that bag, and the average person is going to take about 7 to 10 milliliters of air per ideal body weight. So somewhere around 500 milliliters of air. If you're emptying that entire bag into their lungs, you're giving them far more volume than they need, and you can overinflate the lungs and cause barotrauma. You need to allow adequate time for exhalation. That was the big issue with hyperventilating people, squeezing the bag quickly to get lots of oxygen into them. You were successful in getting a lot of oxygen into them, but you never did allow them to adequately exhale, and as a result, air trapped inside the chest prevented the blood flow out of the chest and into the bloodstream. When we're having trouble getting a patient's chest to rise using a bag valve mask, you can use the acronym Mrs. Opie to help you remember the things you should troubleshoot. if you're not getting good chest rise with a bag valve mask. The M stands for mask seal. Maybe that's not adequate. Readjust that. If you're still not getting it, reposition the head. Maybe you don't have that in the right position. The S is for suction, heavy secretions. The O is to insert an OPA, which may help hold the tongue up off the back of the throat for you. P is pneumothorax or pneumomediastinum, air in the mediastinal space or air in the lung itself. That can cause trouble with ventilation. And then E is equipment failure or operator error. Now, automatic transport ventilators, there's a great debate right now about what really constitutes an automatic transport ventilator. If you look at the one on the top, that typically was what we envisioned an automatic transport ventilator should be. You essentially have three buttons. You have tidal volume, you have respiratory rate, and you have inspiratory time. So those are the only three settings that you can make with that. Where if you look at the one below, there are multiple different settings that you can make. In addition to tidal volume and respiratory rate and inspiratory time, it looks like there's quite a few other settings. Maybe you can blend the FiO2 and do some other things. And that really isn't, it's a transport ventilator, but more on the scope of the practice for a critical care paramedic rather than a paramedic. Some contraindications to automatic transport ventilators include airway obstruction, resistance of the patient, poor lung compliance. You can't feel it if you're using an automatic transport ventilator. You can't feel the lung compliance. Pulmonary overpressurization, because you can't feel the compliance of the lung. Some advantages: they're lightweight, they're portable, they're durable. You can enrich oxygen into the delivery. They do help breathing patients as well as non-breathing patients. They do help intubated patients as well as non-intubated patients. And it frees up a rescuer to do other things once you have it set and ready to go. Disadvantage, many of them work off an oxygen source, so it'll take your small oxygen tank and drain it in about 10 minutes. And again, you can't detect lung compliance, so you don't know if a lung has collapsed unless you're constantly checking for it when using an automatic transport ventilator. Flow restricted oxygen powered ventilation devices or demand valves. Here's certainly a picture of that. I don't know many people that still carry these. They pretty much have fallen out of favor in EMS because of the fact that much like an auto transport ventilator with too high an inspiratory time or too high an inspiratory volume, with these demand valves, you can overinflate the chest by not letting off on the valve soon enough. They're set to go off at 40 centimeters of water. That's their pop-off area. But at 19 centimeters of water, you dilate your esophagus. So if this takes all of 40 centimeters of water to get the lungs to inflate, you're probably putting quite a bit of water You're probably putting quite a bit of air in the stomach with each one of these breaths. It's indicated for patients who aren't breathing or who are apneic. It's contraindicated for pediatric patients because that 40 psi is just too high, and could cause serious barotrauma to pediatric patients. Some advantage: it is really easy to use. You could do a C&E technique with the mask, use your thumb or use your chin to trigger the valve on the top. So it is very easy for one person to use. You get 100% oxygen. You can use it in breathing and non-breathing patients. But the big disadvantage is that, it needs lots of oxygen. You can't monitor lung compliance at all, and it can lead to barotrauma in the lungs if you overinflate them. Here they're just showing you the pictures of the demand valve and how you might use it after applying your PPE. And with a good seal, and again, it's very difficult for a single rescuer to get a good seal with one hand. You just push on the valve on the top. Some of them had a spoon that come off the side, and you would squeeze the spoon, and that would allow air to escape out of there as well. And you hold it while you watch the chest rise, and as soon as the chest rises, you're supposed to let off. And air will be trapped in there for some period of time after you let off, so the chest isn't going to drop like it normally should, but you need to allow adequate time for exhalation. Tracheostomies. Tracheostomy is stoma is a word for a hole. So an ostomy, tracheostomy is a hole in the trachea. Tracheotomy is the surgery that makes the hole, and a tracheostomy is the hole. Tracheostomy can be permanent. It can be temporary. The tubes can be cuffed or uncuffed. They come in a variety of sizes and looks, as you can see here. And we don't expect you to be an expert in the removal and replacement of tracheostomy tubes when they become plugged or go bad. Typically a person who's being cared for by a home care worker or by family members are the ones that are most well versed with this equipment. Some things to keep in mind is that, the stomocytes, these come out of the stomocytes at times, and when they do, you can either put them in. Worst case scenario, you'd have to ventilate the stoma or the hole without one of these tubes in place. Gastric distension, as I had mentioned, is very common when you look at artificial ventilation. It's going to lead to regurgitation, aspiration of food. It's going to affect your ability to ventilate adequately. If you're using cricoid pressure, one of the big disadvantages is that if a person passively vomits, this may keep that from coming up and them aspirating on it. When we consider ventilating pediatric patients, remember the anatomic differences, how we open their airway, how that's different, how it's more of a challenge to seal their airways, how large their tongues are and can get in the way, that sort of thing. You want to choose the appropriate bag size. We have neonate, child, and adult, and the adult usually has around 1,200 milliliters of air. The child has around 800, and the infant usually has around 300 or 400. Dual lumen airway devices, that starts off with our advanced airways. And I think right here, we're a little more than halfway through the slide presentation. So I think I'm going to stop right here with dual lumen airways. And we'll pick up next time with the dual lumen airways. Until then, think about all the things that you're going to be doing in your labs on Thursday concerning airway management. Now we're getting into lots of really neat hands-on things that we can do that will make a difference and improve outcomes in patients who are having trouble breathing. So until next time, I will talk to you soon. Let me